and we have lots of fun. That's some of my staff. But why are we pediatric dentists superheroes? We are generally superheroes, pediatric dentists. Why? Because we actually manage very difficult patients, because children are not smaller version of adults. Working with children is very different with working with adults. It's not like how the endodontist, the prosthodontist, the periodontist, who actually have a very cooperative patient sitting there and who will do what they ask them to do. But we actually treat children who are different, and their responses and behaviors are different at each appointment. So they change each appointment. So I really wish I can hang this in my office every day, but I can't. I have to do my job. I don't have any conflict of interest for this lecture, and I just want to start saying the status of oral health has a significant impact on the general health and well-being of a child. It influences the quality of life of children experiencing to their formative years. Optimal dental health is essential in achieving and maintaining good general health and well-being in children. I almost always, at every lecture I give anywhere in the world, I put this slide up. In 2008, the British Dental Association president said, only the best is good enough for our children. Only the best. Because if we can't provide our children the best possible dental care, we are really failing our children. So it's very important to actually provide high quality care for our children. So my topic today is pulp therapy in primary and permanent dentition, with a focus on the recent changes in pulp therapy management, namely vital pulp therapy. My slides do have some information on primary pulp therapy. If time permits, I've got only less than 22 minutes left. If time permits, I will cover that. Otherwise, I will just move on to vital pulp therapy. There have been significant recent advances which have radically changed our understanding of pulp biology. The current research recognizes pulp healing capacity and defense mechanisms which have really shifted treatment paradigms for both primary and permanent dentition. Traditional perspectives consider pulp inflammation as a progressive condition resulting in pulp death. Treatment approaches always favored complete pulp removal in permanent dentition, even when the pulp was only partially involved. Recent research reveals that pulp possess remarkable defensive and reparative capabilities which could be leveraged through minimally invasive interventions. The pulp response to injury, caries or trauma through complex cellular and molecular mechanisms. In a slowly progressing carious lesion, bacteria produces bacterial products diffuse through dentinal tubules. This triggers a controlled inflammatory response associated with increased odontoblast activity and reactionary dentin formation. The terminologies we generally use are classifications. The traditional diagnostic terminology is reversible versus irreversible pulpitis. It's actually becoming increasingly inadequate. Alternate classifications have been proposed and consensus efforts underway to align terminologies with the current evidence, which I will show soon. Additionally, there's a lack of consensus on the pulpal diagnosis. Terminologies used by pediatric dentists and endodontists. We often have slight differences in terminologies. So the diagnosis is where it's very important because that makes us, which helps us to create a good treatment plan. So accurate diagnosis or pulp status remains a significant challenge, especially in pediatric dentistry. Clinical symptoms and traditional testing methods may not reliably reflect the histological status of the pulp. It's impossible for us to check the histology while making a diagnosis. Hence, there is limitations, and the current diagnostic tools which we use for diagnosis of pulpitis, particularly to assess the inflammatory status of the pulp, have prompted investigations into biomarkers for pulpal diagnosis and prognosis. So the International Association of Dental Traumatology is at the moment in the process of revising all their guidelines because they've been looking into all the biomarkers, and hopefully in July this year they will come up with the new guidelines. So there's been a huge shift, a paradigm shift in how we look at this. So the recent evidences have challenged traditional treatment paradigms regarding the management of deep caries, pulpal exposures, and pulp injury. The concept of just irreversible pulpitis is being reconsidered as evidence emerges that inflamed pulp tissue, once we considered as irreversibly damaged, may have healing potential under appropriate conditions. And appropriate conditions is something we really need to be aware of. There is an emphasis on pulp preservation, a lot of emphasis on pulp preservation, using minimally invasive pulp therapies such as partial pulpotomies, which consider pulp inflammation as an existing continuum, and it still will try to aim to preserve the pulp vitality and function. So as Luke mentioned earlier, the bioactive materials are playing a huge role. The development of bioactive materials, particularly the calcium silicate-based cements, have significantly influenced the treatment outcomes in vital pulp therapy. These materials have clearly demonstrated their superior biocompatibility and ability to stimulate reparative dentinogenesis compared to traditional materials. So, in primary and young permanent teeth, pulp therapy usually presents unique challenges due to their limited lifespan in primary teeth and the presence of a successor. However, the management of immature permanent teeth requires special consideration due to their thin dentinal walls, open apices, which necessitate approaches that can promote continued root development. So this is one of the most downloaded and most quoted paper in dental literature at the moment, because IAPD, which is the pediatric organization, organized a consensus in a global summit in Porto in 2024. And then we have a consensus-based recommendation on pulp therapies in primary and permanent teeth. At this forum, all the top clinical and research experts in pulp therapy or pulp biology came together and worked for a whole week to come up with a consensus. And I've actually requested the pediatric dentistry department to use that to download the paper, which is free access, so you can just get that paper from the internet. So vital pulp therapy aims to preserve and maintain vitality and function of the dentinal pulp after it has been affected by caries, trauma, or due to a restorative procedure. Vital pulp therapy is conservative, biological driven, an approach designed to retain a healthy, functioning pulp rather than just removing the pulp. So various procedures involved in vital therapy and the requirements for vital pulp therapy. The procedures we usually use are indirect pulp therapy, direct pulp capping, partial pulpotomy, full pulpotomy, and the indications are often reversible pulpitis, caries of traumatic pulp exposure, apexogenesis, permanent teeth with mature roots. There's new research and evidence which supports the use of vital pulp therapy in these teeth. And the requirements are we need a pulp effective bacterial control and total seal. As you heard from Luke, seal is the deal. Without a good seal, nothing works. We also need to keep into consideration use of bioactive materials and more than anything else, case selection. So we've been looking for years, decades, for what is the most ideal pulp dressing material. Ideally, it should be antibacterial, it should be non-toxic to surrounding tissues, it should promote healing of radicular pulp, it should form a dentin bridge, and ideally, we just don't know what this material is. However, with the advent of the bioactive biosilicate cements, we feel that we might actually have the right material. So, the most commonly used materials now are obviously calcium hydroxide, MTA, biodentine, and obviously other calcium silicate cements. With vital pulp therapy, one of the most important things for us is to differentiate what we do in primary teeth and permanent teeth. As there are so many dental students here, you really need to spend the time differentiating the two modes of treatment. So primary teeth versus permanent teeth. I won't go through the details of this because there's lots. All I would suggest is look through the literature and or your study material and differentiate between primary versus permanent teeth. Now, if you look through the latest consensus paper, which was published recently, you get a real idea about how to go about the initial assessment of pulp. You can clearly see that there is a strong recommendation and there's a conditional recommendation. And again, please do get that article and have a look through it. And it also differentiates between primary teeth and permanent teeth. Again, you can clearly see there is the strong recommendation and a conditional recommendation. Way too much material to discuss, but I just put it out there so that you can look through the literature. Now, pulp therapy in primary teeth. Due to lack of enough time, I'm just going to skip through this very quickly because there's plenty of factors that influence the decision to retain primary teeth. I'm very happy to mention that the pulp therapy techniques used by the staff at the National Hospital of Odontostomatology are on par with what the rest of the world are doing. They are doing pulpotomies with MTA. They're very much on par with everything else. So I really don't think I need to go through this in detail. They're doing very well. As for factors influencing decision to retain primary teeth, obviously we look at the child's cooperation. Can the work be performed in the dental chair? More than anything else, the decision is based on can the child cope with the procedure. I urge all of you who treat children, when you create a treatment plan, no treatment plan is good if the child can't cope with the procedure. So it's very important to actually check whether the child can cope with the procedure. So more than anything else, case selection, case selection, case selection. You really need to select your case well because only then you get success. I'm just going to skip pulpotomies because it's a very common technique. Everybody knows pulpotomy, and if your students, your tutors will teach primary pulpotomies. And we use MTA now. Most of the units around the world use MTA to do primary pulpotomies. Just a couple of precautions when you do primary pulpotomies. Please try and not cause damage to the base of the pulp chamber. And if you use a round burr, please don't perforate. But on the brighter side of things, if you're using MTA, you might get away with it because the MTA will seal it very well. So the MTA success is very good because even if you stuff it up, it does work. So, Formicrysol, nobody uses Formicrysol except a very few countries in the world, but I'm clearly told that you don't use Formicrysol anymore. And now I'm going to jump through to another article which is just published last month, where Monty Dugal and his team from the UK and Doha have actually put in a paper call for action, asking whether pulpotomy for treating primary tooth with irreversible pulpitis. I almost fell off the chair when I actually saw this article. It doesn't mean that you have to go and start doing pulpotomies for irreversible primary tooth. However, it's worthwhile having a read of the paper, which is again free access, so that you get an idea about what could be coming up, especially since we're using MTA or Biodentin. Now moving on to the topic which I really want to mention over the next 5 minutes is vital pulp therapy in permanent dentition. So pulpotomy in permanent dentition, we've always done it for trauma when we do the swept pulpotomy. However, there's an increasing number of pulp therapy being performed in permanent dentition. So this is where the biosilicate cements come into play, because vital pulp therapy maintains the vitality of the pulp of a tooth which is affected by caries, trauma, or other reasons. More recently, with the increase in MIH, or molar incisor hypomineralization, which many of you would have seen or familiar with, there is an increasing amount of patients who require vital pulp therapy in their permanent molars. So hence, this is where it really could be a potential alternative to root canal treatment in molar teeth, especially after caries pulp exposure, and even if there are signs and symptoms indicative of irreversible pulpitis. And this was the big topic of discussion during the consensus meeting at the Global Summit. And the consensus paper clearly states that vital pulp therapy in permanent dentition, even if there is signs of reversible pulpitis, is something to consider. So we know different type of pulpotomies. We have partial pulpotomy or complete pulpotomy, even though when I was a student, I was just told pulpotomy means removal of the full coronal portion of the pulp, except for a swept pulpotomy. But the indications for a partial pulpotomy in permanent dentition is if it's a young permanent tooth, there's a caries pulp exposure, traumatic exposure, which we all do, and I'm sure you all do here in Vietnam as well, where the pulpal bleeding can be controlled within several minutes with some irrigation, with a bactericidal agent like sodium hypochlorite, and then there's a diagnosis of normal pulp or reversible pulpitis. And remember, I mentioned earlier, there's a lot of debate going on between reversible, irreversible, or where there's something in between. So, vital pulp therapy in permanent teeth, if you look at the screens on two sides, you might be more clear. You can see there's a large lesion there, where there is some apical changes. But in lesions like that, we now have started to do vital pulp therapy using MTA or Biodentin with fairly good results. And that's where the consensus statement is. So, vital pulp therapy in permanent dentition is something which is really being advocated and promoted. I would urge you to read the literature and consider incorporating into your practice. Again, case selection is very important. So MTA or Biodentin is the material of choice, and obviously a permanent interim stainless steel crown is also very important. As for trauma, everybody is aware of vital pulp therapy. We use a swept pulpotomy with an MTA. Excellent success rate with good case selection. and most importantly, as Luke mentioned, rubber dam isolation. You need rubber dam isolation to get good results. So, in conclusion, we actually are at the cusp of some significant changes in how we manage pulp therapy in permanent dentition. And in summary, I would like to mention the following. Vital pulp therapy is something we need to look through. There are significant changes, possible changes coming up with primary dentition and pulp therapy. There are many common primary tooth techniques which I have skipped through because that's something you would do on a daily basis. The young permanent teeth management has been discussed. There's permanent tooth procedures which I mentioned, which is also in the literature. There are some contemporary principles in volatile pulp therapy. However, material consideration is the most important thing with the use of bioactive materials like calcium silicates, such as MTA and biodentine. Thank you very much for your time, and happy to answer any questions after the session. I did stick to time. That's a rare thing.
Yes, thank you.